Hi, good evening everyone. Tonight I am doing an Instagram live with Dr. Smikle, who is the very popular medical director of Laurel Fertility Care based in San Francisco, USA. And we're going to talk about Googling it. So everything that people Google and all the questions that he gets asked that people go off and Google whilst they're having treatment with him. So he will be answering questions that you want to know more about, so you don't have to spend hours on Google worrying that you're doing something wrong or should be doing more, all the things when I was having treatment. So we thought this would be a very useful topic to talk about. So he should be joining any second. Hi to those who are joining. Hello, Dr. Smikle, how are you?
I'm doing okay. How are you doing? Thanks for
Yes,
inviting
fine,
me
thank
back.
you. Nice to see you again.
Great seeing you. Great seeing you.
I've just given a brief introduction to yourself and also Laurel Fertility Care and our topic tonight. So please could you introduce yourself to any new followers, and then we'll start talking about commonly asked questions when it comes to people going off and doing their own research, maybe self-diagnosis and the dreaded Google during fertility treatment.
Well, thanks for that. I'm Colin Smikle. I'm the medical director at Laurel Fertility Care, who've been caring for women and providing opportunities for women to build their families and couples to build their families for more than 17 years now, serving couples throughout the world. Also, see quite a few same-sex couples, single parent by choice. So we're happy to provide information for you.
Fantastic, thank you. So when it comes to Googling, what do your patients commonly go off and Google whilst they're having treatment with you, or come to you for their first consult, let's say, with questions that they may have read up on?
I think one of the things that commonly comes up is everyone is looking for how to improve their own opportunity. And so what the first thing they'll look at is they'll look at information that supposedly relates success rates. So a common thing is, regardless of age, someone will come in and say, even before beginning any treatment, before even getting any testing, we'll ask the question, so what's my success rate? And that's commonly a way that patients will actually either choose a clinic or they'll choose to look at clinic parameters without really asking specific questions related to themselves. And I think that's the hardest one to answer.
Mm-hmm.
It's not to say that success rates aren't important. It has to be put into context with everything else and address your own concerns. So the important thing is not only to look at, what your specific diagnosis is, but also, what other things can influence your outcome. So before asking, what's the success, if you will, maybe the better question would be to look at, specific, questions related to diagnoses. Many times patients will come in either because they're coming from another fertility practice and they have some understanding what their diagnosis is, and they've actually done a lot of research on the internet regarding those diagnoses. But sometimes those diagnoses may either be incomplete or may actually be inaccurate. So it's important to kind of know not just what the diagnosis means, but also what it is in context with your own sense for success.
Mm-hmm.
And I think the important thing to look at is just that, just like anywhere else, the success is going to relate to an idealized person, not necessarily the person who's going through that assessment. And that's important to kind of understand. So it's understanding where you are relative to someone else, but looking at your own parameters to kind of help with that diagnosis, if you will, or that option.
Yeah. What I was guilty of was going to an initial consultation, starting treatment, going to the first, let's say, scan, and the specialist looking at how follicles were developing, and then going off disappointed that there weren't as many follicles developing as we would have liked, for example. And then reading blogs from, random people from, let's say, 10 years ago and thinking, well, if that person had X follicles. How many am I going to have by the time we get to egg retrieval? And then, when it gets to that stage, thinking, well, if I have that many, what percentage are going to make it to blastocyst? And then, and so on and so on and so on. So do you get lots of people doing that as well?
We do get lots of people doing that, and the thing to realize is just that it rather than simply going off and going into that deep hole to ask those questions, it's to get a better understanding from your physician. What were the goals in terms of the treatment option they're considering now, because sometimes it's specific in terms of how many follicles we're trying to recruit. And someone who's going through what we call a minimal stimulation cycle, some people will call it a natural cycle or a low stimulation cycle, you don't want a lot of eggs. So to compare yourself to someone who basically has a lot of eggs is not really even relevant, because that's not the goal. Also, if you're not able to have that many eggs because there's diminished reserve or there's endometriosis or there are other factors, that's again something where you're comparing apples to oranges, and that's a really challenging thing to kind of put yourself into that position. Going through infertility treatment is already fraught with a lot of, I would say, self-doubt and a lot of self-blame. And so therefore, the better thing may be to do things that's going to put yourself into getting as much information as you can, so you can optimize your treatment rather than getting more information to put yourself in a sense where you're going to feel more bad. You're going to feel worse about your situation, because that's something that's never good to do.
Mm-hmm. And when it comes to other things that people Google, as well as sort of success rates and chances of success based on how the cycle's going, etc., do you find that people Google holistic things that they can be doing in therapies to improve chances as well?
Especially if one has gone through some treatment and it's been unsuccessful, or they're actually switching from one clinic to another, they're always looking for other things that are going to be supportive. We call them adjuncts to treatments. So they'll talk about doing acupuncture, or they'll talk about doing a lot of using some sort of herbal therapy. And there is information to say that to support all those things. I think the thing that's important to realize is just that you go from basically the ones where you had long confirmed information regarding these specific therapies to a broader industry that now became a business in terms of managing it. Using acupuncture as one specific example, I'd say that, because there has been a tremendous amount of benefit that's been shown in the certain situations where acupuncture does help, you've actually created an industry now where you have a lot of providers who do acupuncture now feel that they have the capacity or the knowledge to do acupuncture related to assisted reproduction. And that may not always be the same thing. Because just as you have physicians who aren't really trained to do some things, you have acupuncturists who aren't really versed to do what you're actually asking for. So it's going to be important to look not just at those places and what they do, but what their history is and what they've undergone. And it's not to say that it's not something that you can get a lot of benefit from. It's simply that you do need to do some research as well in terms of saying, well, just because someone puts infertility on their site doesn't mean they can actually accomplish that goal.
Yeah, that's a really good point. When there's so much out there, especially with COVID and people looking online for everything, how can people know what to trust and where to go for reliable information?
I think you do need to trust either the clinic or some other referrals from sources that you have, because many clinics who do have some sense in terms of basically alternative measures may end up having a list of providers they have trusted, have worked with, that may be a great resource. Those individuals in turn may not actually have the capacity to see all the patients we refer, but they have a network of physicians or acupuncturists that they trust, or therapists that they trust. So it's building a supportive network of people that are like-minded or are actually going to be playing on the same platform rather than actually, going Yelp or going by other reviews, because that often doesn't lead you down the best path in terms of saying, well, that's what you have. The challenging thing, unfortunately, is just that, many of those services are actually provided in areas that are pretty densely populated. So if you are, in a rural area or one where there's not as many choices, then you're stuck. You don't really have a lot of choices in terms of what to do. So you may have to trust your acupuncturist that is local to learn the services, if you will.
Yeah.
And I'd say the best way to do that is to have conversations and really push back, just like you push back with your physician to kind of get information, push back on those individuals to kind of provide, a lot more defined way in terms of managing things.
Mm-hmm. That's great advice. And so for people who might be kind of comparing their situation to other people's that they've read online, what would your
Mhm.
advice be there? Because every situation is unique, isn't it?
That part I think is the hardest one to kind of do, and I'd say that's probably the worst thing for patients to do to themselves, because you're right, no two individuals are the same. Your friends who've gone through fertility treatment are not going to have the same, either outcome or the same story as you do. So therefore, the important thing is to basically stick within your story and use those measures to provide you the emotional support you need to go through treatment, because we realize that the treatment process itself is actually really stressful and you need that supportive environment to kind of go through. But comparing yourself is just going to be fraught with a whole lot of things that are going to make things more painful and more uncomfortable. So I don't think that's actually worthwhile. Even patients with polycystic ovarian syndrome, PCO, will end up having varied degrees of their experience in terms of going through the process, even with the same number of eggs, just because there's a whole lot that may actually be in tune, if you will, doses of medicines, how aggressive the stimulation is, how much monitoring is actually done. All those things are going to basically make those experiences very different. It also relates to fertilization rates and pregnancy rates. All those things are going to be important. So it's better not to compare yourself to somebody else, but basically get the parameters, ask questions, push back. All those things are important and all true, but it doesn't necessarily mean your experience is going to be the same as someone else.
Totally. And if anyone has any questions whilst we're talking about this for Dr. Smikle, please feel free to ask. What other questions do you find your patients come in asking? Are most of them well read and have done some research themselves?
I do think that patients are actually very well educated in terms of, just in terms of their histories and also, some of the causes. There's some individuals who would prefer to at least find out, or if they're beginning their journey, they may actually need, they'll ask fewer questions. But I think people get pretty in tune pretty quickly. I do think that the other things that come up often are, even further, I'd say more, um, um, I'd say off harder ones to describe in terms of treatment options. Talking about intralipids or basically IVIG, other other means that people look to, especially after repeated unsuccessful attempts, to try to improve their opportunities, improve their options. And although it's actually really hard to say that you should or shouldn't consider all these, because any of those situations are ones where in a certain population of patients, you will definitely have benefit for those treatment options. It's not something you can broaden to everyone. And so you end up having people going through some exhaustive measures and even traveling to different parts of the country or the world for treatment that just are not proven to be successful, or actually there's no benefit that you've shown. And there's a number of randomized control trials that actually support the fact that those probably aren't going to be helpful. Still, sometimes patients get desperate and they'll go through whatever measures they can to get their success.
Mm-hmm. Yeah. And so would you rather that patients ask you questions when they're having treatment with you versus going off and trying to work things out themselves?
Yes, I'd say that's, but I'd also say that, I think it's any physician who is actually going to feel challenged um, or feeling that they're not going to be able to answer those questions or feeling that they have all the answers are ones that are going to be really pulling themselves, they're selling both themselves and their patients short. So I'm always willing to learn from patients who they've either gone through other programs before or they've sought second opinion and they've brought that information back. So therefore we can all experience and learn from, especially given the fact that we have fewer in-person professional conferences. Sometimes someone will actually go through a different program, and that's treatment option is not something that we'd either considered or we considered and actually haven't been successful before. But we've had interpretation of this information from other people's experience, and we learn from that. So I think that's helpful. The reason why that becomes important is just that first, patients can then be part of that conversation, be part of that decision, and feel like if they're getting the care they need or they can. But by no means it doesn't mean that that person's being experimented on. And I think that's actually the difference in terms of
Mm.
how someone goes, well, how do you do this? Because I think it's important to say, well, this actually been shown to work, and therefore this is one of the things to go through. And you can actually then expand on that. But the part about just trying something just to try, sometimes it gets harder for the patient as well. So that's important to kind of understand.
Yeah, absolutely. We've had a couple of questions come in which aren't necessarily related to
Mm-hmm.
evening, but it's just some personal questions that have come in. Do you have time for a couple?
Definitely. Mm-hmm.
Let me just see what we've got. Someone's asked if they're looking for a specific gender, is undergoing IVF the way to do that, or would IUI work for that potentially for someone with PCOS?
Right. So there were a couple of other treatment options available to patients who were going through less aggressive measures. There are two approaches, one called the Peterson method and the other part called the microsort method for sperm separation. The way that was done by because of the differences, very slight but very small differences in size between the sperm, you could sort that sperm and actually sort male from female. And so that was purportedly the reason to kind of offer those therapies. The downside to that is just that even under the best of circumstances, you can actually identify female sperm in about 75% of cases, male a little bit less in about 70% of cases. So you'd end up having patients who are getting pregnant in 30 to 35% of the times, or 25 to 30% of the times, they were getting pregnant with a gender that was not one they considered. So a lot of facilities actually went away because it's a lot of these therapies are actually, number one, laborious, and number two, not fraught with a lot of uncertainties, moved to going through genetic testing through in vitro. With in vitro, and you're doing the genetic testing on the embryos, that's part of the diagnosis in terms of finding out. Clinics may end up having different considerations in terms of basically doing what we call sorting for gender. But that information is available, and it's a lot more certain than going through the microsort or the other measures for sperm separation. So oftentimes patients will turn to that as a means in terms of being successful. The benefit of that is just that the certainty is greater than 99%. So therefore, there's a higher chance of success in terms of going through the cycle and a higher chance in terms of achieving that goal. But that's something that sometimes patients will look at because it's a greater degree of certainty.
Is that something you offer at Laurel Fertility Care?
We do, because it's part of that information in terms of what's actually found when we're doing the genetic testing on the embryos. Some patients either don't want to know or they want to leave it to some choice, if you will, and they'll look at the best embryo because sometimes the gender that's actually identified may not be the one that is the best embryo.
Yeah.
So that's important for them to at least know as part of the conversation. But yes, that's something that we offer here in our practice.
Someone else, thank you for that. Someone else has asked, so they're trying for a second child. They got pregnant fine the first time, and they've now undergone tests. Everything seems normal. Her husband has a slight low morphology. They've been referred for IVF, and she's wondering, is this the only way that it might be possible for them to conceive?
That's a great question from the standpoint, and a lot of it's going to depend on her age. So therefore, that's the first thing to say. And if all the tests are normal, meaning the fallopian tubes are open, sperm test, the morphology is slightly low, but everything else is okay. Her hormonal profile is actually normal. She could continue trying or try with other measures. The only disadvantage to that is the chance of success may not be as high as IVF. And there are numbers of studies to show that basically in women, even though they've gotten pregnant easily in the past, trying for that second child or trying for that pregnancy after, say, 6 or 7 months, it may be that chance of success may diminish. So therefore, IVF is going to be the best way to kind of get back to that normal sense, if you will. Sometimes what you'll actually look at is that IVF allows you to identify things that are subtle, but you aren't able to identify under other circumstances, because you'll separate sperm, egg, fertilization, and you look at each of those interactions to see what's different. And you'll find information that you may not actually be looking for. You may end up having normal appearing sperm that just doesn't fertilize the egg, or fertilizes it only under certain circumstances. And so therefore you can bypass that by going through and doing ICSI and other measures, that intracytoplasmic sperm injection. So IVF becomes a great tool to identify areas that may actually not be otherwise available in terms of testing.
Okay, thank you for that. I hope that's answered that person's question. And someone else has asked, have you seen improvements in egg quality with a change of medication or through supplementation?
I think that's again related to age. So therefore, I'd say that age is the one thing that we have not found a tool to overcome. So I'd say that we have seen improvements, benefits, if you will, in patients who are taking supplements. CoQ10, one of the things that people talk about. There's no magic bullet, so therefore, that's important to realize. It's just that's just one of the means that may actually improve someone's parameters. And that parameter may be slight. It may just be that it increases the number of mature eggs from, by 1 or 2. But those 1 or 2, those are normal ones. That's all the patient may need in terms of building their family. So that's the important thing to know.
Mm-hmm. That's probably one of the high Google searches, isn't it? Mm-hmm. How to improve egg quality.
Exactly. Because one of the things is just that it's hard for someone to then have to realize that the only option after, not using their own eggs is actually either to use egg donors or embryo donation as a means for building their family. And that's a hard leap for someone to take, especially someone who's younger, because then they're figuring, well, how am I going to actually be doing this when, I have all these options or opportunity? And it's a very, very hard thing for some people to understand or either come to grips with.
Definitely. And then we have another question, which is about fibroid removal. In 2021, recently got diagnosed with high TSH, on thyroid medication for the last few days, and going into the second IUI, CD7, and questioning whether it may work or not, which obviously you don't have a ball, but thoughts on that situation, please.
Was it a thyroid or a fibroid that's the issue? Because it seemed like it was...
It was both, actually.
Okay, so
sorry, she had a fibroid.
It's okay. That's understandable.
And she's on thyroid medication, so we might have to wait a minute for her to ask that again.
Right. To just answer that generally, I'd say that the goal, there are a number of studies to show that the best way to maintain a pregnancy in terms of patients with thyroid disease is a thyroid level that's below what is considered the normal range in the normal population. So the goal is to have TSH under 2.4. So therefore, that's an important measure that we all strive for. It doesn't mean that someone who is just above that or is slightly higher can't try. It just means that they may end up needing to be on supplementation to bring that down, because we know that in patients who have really high thyroid hormone levels, that there is an increased risk of miscarriage. We also know that the placenta makes a hormone that acts very similar to thyroid hormone, so therefore that may also make it so therefore the patient may end up being stimulated. So we really try to now measure those hormone levels to make sure it's in that range. As far as fibroids, that's different. I think it has a lot to do with the location, whether it impacts the cavity. So therefore, if it does impact the cavity, then that may be something that needs to be removed or at least identified as an issue. Many times, if it's not part of the cavity, then it doesn't need to be removed. But it's, again, one of the things that you'll have to look at.
Mm-hmm. And someone just asked, is it a good idea to do 2 egg retrievals, one after another, to increase chances of getting good eggs? And I've heard of this before, doing back-to-back cycles for people who might have low ovarian reserve. Is that right?
Well, the biggest thing that it allows you to do is within a certain time period, increase the cohort of eggs. So it doesn't necessarily improve egg quality. There are different things that you might actually do in between the 2 cycles to try to, stimulate and improve that part of it. What it does allow you to do is maybe to increase the egg number. So especially someone who wants to build a certain family size, it may be important to basically go back-to-back cycles just so you can kind of say, plan your family accordingly. What I mean by that is that let's say someone goes through and they go through an IVF cycle now and they're having challenges and they do get pregnant. That pregnancy will last typically, 10 months, and then you'll actually breastfeed for 6 to 12 months. So the next time the person is going to have the opportunity to try again is 18 to 24 months. That's a very long time from the standpoint of planning a family and then having some changes to the ovarian reserve. Simply because during pregnancy and during breastfeeding and everything else, that ovarian reserve is still going to go down. It's not going to change. So in someone trying to build their family, it's going to be important to basically plan that accordingly. And it may be better to go through all those cycles up front. So you have all those embryos stored and you know what they are. So therefore, time becomes less of a factor. So therefore, that's actually what the best way, if you're looking at in terms of basically from embryo crowd preservation for family building, to build the family size you want. And that's a common goal that people sometimes do now.
Is that something you suggest to patients who might be older and have a lower egg reserve?
Definitely. One important question to always ask, and when we ask in every initial visit, is what's your family goal? Because a lot of times when patients are coming in, their goal at that initial appointment is to get pregnant. And they're not usually looking at or asking the question is, what family size are we looking at? So if you step back and ask that question initially, it then allows them to say, well, what am I going to do to build that family size? And then for some people, it's still 1, and then that's actually fine. Then you can actually tailor or change what your plans are to allow that to occur. If they're thinking about 2 or more, that may change some of the things that you actually recommend them doing. So that's an important part of the conversation.
Mm-hmm. Thank you. Just going back to, I just read this person's message.
Mm-hmm.
Thank you. So nutrition to help before a transfer. There's lots of information out there. I guess I was really concerned about doing things wrong by taking the wrong advice. So what would be your suggestion there when people are looking online for support and help for that?
I think the biggest thing to realize is just that if you look at the world population as a whole, people have gotten pregnant with a various amount of diets that, some horrible diets. So therefore, that's another way that I've seen that people beat themselves up. I think the best way to think about this is to eat healthily. So therefore, you're actually not going to extremes. So not going extremes in terms of going through, one diet or another. And so that's going to be the important factor. People have actually asked, well, I'm vegetarian. Does that mean I have to start eating meat in order to get pregnant? And I go, a third of the world are vegetarians, and they seem to have families. That doesn't seem to be an issue. So I do think it's important to make sure you have the right nutrients and the right vitamins, so therefore you can kind of basically go through and support the pregnancy. But it doesn't mean you should actually have to change your diet. If you're going through extremes, if you're basically going to McDonald's every day, that probably isn't a healthy diet for anyone. So therefore, I'd say that that's a different issue they have to consider.
Yeah.
But I don't think there's any specific diets that you can say is going to basically be the best diet, other than eating healthily and staying away from certain things.
That's great advice. Thank you so much, as always, Dr. Schmeichel. We've had a
Hmm.
ton of other questions that have popped up, which I would suggest people reach out to Laurel Fertility Care and book a consult with you. You do them remotely as well, don't you, for anyone who's not in the US?
Definitely, we do that. We do. We talk to people from all over the world, so we'd be
Mhm.
happy to talk to you.
Great. So feel free to contact them directly, or you can DM me and I can help put you in touch. But that was wonderful information as always. So thank you so much for your time tonight, and thank you to everyone for joining.
Oh, thank you again, and thank you for having me aboard. All
Have a
right,
good day, everyone.
great.
Thanks a lot.
You too
Bye.
now.
Bye.
Bye bye.